Hi, this is Sherry Shabowski from Medical Education in Minutes. This is another in our classic clinical presentation series. And today we're going to meet Phiily Amos. Meet Jessica and her 2-year-old son, Phiily Amos. The family is happy, healthy, and terrific. Phiily Amos is a toddler, just learning to run and climb. He is constantly having falls and bumps, just like every other kid his age. But Phiily winds up with a lot of bruises. So Jessica decided to take Phiily to the doctor. On examination, there are in fact a lot of bruises. But otherwise, his examination is normal, and his blood tests are normal. The doctor asks Jessica, "Do you or your husband have a bleeding disorder?" "No, we are very healthy." This provokes the doctor, asking Phiily to speak to the police. What Phiily has is hemophilia A. It is a recessive sex-linked disorder, which primarily affects males, causing a bleeding disorder. Females can be carriers and asymptomatic, passing it on to their male progeny. There is no demographic distribution, no racial predisposition, no socioeconomic predisposition. The bleeding disorder can usually be determined by taking a good family history. This is how the sex-linked trait is passed on. There is an abnormal F9 gene on the X chromosome of the carrier mother, who has no symptoms at all. Either her mother was a carrier or her father had hemophilia. This mom, who is a carrier, has a 25% risk of having a hemophiliac son like Phiily, and a 25% risk of having a daughter who is a carrier. If she wasn't aware that her dad had hemophilia, her mother might have been a carrier too. If the father was a hemophiliac, the son would not have hemophilia. Rather, in our case, it would have been the maternal grandfather who had hemophilia, making the mother a carrier who gave it to her son. The classic skip a generation trait. But let's talk a little bit about the bleeding and what hemophilia actually is. What happens when a blood vessel is injured? Well, platelets will come in and stick to the area, forming the beginning of a clot. And then the coagulation cascade is activated. How does the coagulation pathway work? Well, that damage to the blood vessel will trigger the intrinsic pathway, just like it triggered the platelets. The extrinsic pathway is triggered by tissue trauma. The pathways both go through their own cascade of factors, coming together at factor 10, which, when activated, will convert prothrombin into thrombin. Thrombin will convert fibrinogen into fibrin. Fibrin weaves into that sticky platelet clot, causing it to become a little more stable. Thrombin will also activate factor 8 into activated factor 8. The factor 8 has a very important job. What it does is it cross-links the fibrin and makes a stable clot. In hemophilia A, the amount of factor 8 available is less than normal, and sometimes drastically so. That means the hemophiliac cannot form a stable clot when there is injury to a vessel, and this can lead to serious bleeding, much more significant than you would see under normal circumstances. What happens if you can't form a strong clot? Well, joint and muscle bleeds are very common. Brain bleeds are frequently lethal. If the child is circumcised, they may bleed significantly at that time, therefore helping to make the diagnosis. Dental procedures and surgeries can be very dangerous for a hemophiliac. The treatment for hemophilia is to replace the factor VIII that is needed. Factor is dosed in international units. Basically, you take the weight in kilograms and multiply by the desired percentage increase in circulating factor VIII than you want. Then you multiply that by 0.05. The percentage you want to increase it is going to depend on the situation. Minor bleeding would be something like minor hemarthrosis or oral bleeding, or maybe a minor muscle bleed, in which case you would want to increase the percentage of factor VIII by about 20 to 30%. Moderate bleeding would be a hemorrhage into a joint or muscle or known trauma. In these cases, the target increase is 30 to 60%. With major hemorrhage, like GI, intracranial, intraabdominal, or intrathoracic hemorrhage, or the risk of one of those, the goal would be to increase the factor VIII to 80 to 100% of normal. These doses are repeated as needed every 8 hours. The prophylactic and post-op dosing will depend on the surgical procedure and the risk of serious bleeding. As a reference, the expected percentage factor rise is 2 times the international units that are given divided by the weight in kilos. Under routine circumstances, every day without bleeding, the hemophiliacs are given approximately 25 IUs per kilogram, and that is given 3 times a week to prevent spontaneous bleeding or excessive bleeding. Historically, hemophiliacs were given factor VIII concentrate that was pooled from the plasma of many different people. Sadly, before the transmission of HIV was clear, blood donations were not tested. Since blood was pooled from many sources for factor VIII, hemophiliacs got HIV from their life-saving factor. Now, factor VIII is man-made, and that HIV risk is gone. This disease emphasizes the third rule of managing hemorrhage. Number 1 is place pressure or gain proximal control of the bleeding. Number 2, replace the losses with IV fluid or by transfusion as needed. The last that people sometimes forget, but they must be cognizant of, is that coagulation disorders may be contributing to the hemorrhage. So unless you think of it and recognize and correct the coagulopathy, the bleeding may continue no matter what you do. Why was the doctor involving the police? Well, Phiily Amos had unexplained bruising all over his body, and the doctor is a mandated reporter for potential child abuse. His blood tests were normal, and his family did not have a history of bleeding. So, child abuse was a reasonable assumption for the doctor. This unfortunately happens to many victims of this point mutation. It can be spontaneous and not be passed down from the parents. In these cases, the family winds up having to answer to the Department of Child and Family Services, accused of child abuse. This is not uncommon. Ultimately, more specific blood tests make the diagnosis, specifically a factor VIII level, and the family's reputation is restored. All right. Thank you for learning with me today. I hope you enjoyed this classic clinical presentation. I'll see you around for the next one. Keep studying.